Well, hello and welcome to HealthLine this Tuesday evening. I'm Jennifer Blomquist. I have the privilege of hosting the program tonight. If you're one of our regulars, you probably know the routine, but in case you're new, let me go over kind of the whole strategy so that you know what is going on. We are live in the studio, and that's why we keep our phone number up at the bottom of the screen so that you can call in or you can text in a question to our guest. We have an orthopedic surgeon here tonight. He has been with us before, is a wonderful guest, and is more than happy to answer any questions you may have. His specialty is the back, so we're going to be talking about spine surgery. But if you have something kind of related to that, please don't hesitate to give us a call or a text. So real quickly, the phone number, if you want to call, is 969-2720. It is a free call. If you're outside of Fort Wayne, just put 866 in front of there, and we'll get you through. We don't throw you on the air. You talk to a very nice call screener, and they can either put you on live to ask your question, which is, I would say, the better way to go, because maybe Dr. Smith needs more information from you to give you a better answer. So if you're up for it, if you're brave enough, it's really easy to do it that way. Or if you prefer, you can just tell the call screener your question and they'll relay it to me and we'll get it answered that way. The text number is a little different. It's 969-2730, and I want to assure you that it's private. We'll keep your phone number private, so you don't have to worry about that. If you feel comfortable giving us your name maybe and where you're calling from or texting from, that would be great, and that's a really easy way to get your question answered too. Just text it to us and we'll get that answered. So wanted to just keep you aware of all that. In the meantime, as I said, Dr. Micah Smith is our guest tonight, so we're going to go ahead and introduce you to him. So thank you so much for coming back. Appreciate it.
Absolutely. It's always a pleasure.
And you've been doing this quite a while, so he knows it all. So yeah. We're going to talk about different kinds of spinal surgeries that are available. And we'll start that conversation, but like I said, feel free to interrupt at any time with a question. So I think in general, because we do a lot of we've done a lot of spine shows over the years, because there's almost always somebody in your circle of friends or family that you know that, oh, they have chronic back issues, or they're always having something going on with their back. So it's a pretty common issue for people.
It is.
And surgery is scary. I mean, most people, that's the last kind of surgery they'd want to have.
Yeah.
But you guys don't jump into the surgery. I know you try minimally invasive techniques first.
Exactly. So we always try conservative management first. Yeah. Okay. So whenever we see somebody in the office, whether they have neck pain or back pain or anything like that, the first thing is to try medications, yeah. Maybe some physical therapy, and see if we can manage it conservatively from there. Depending on what the issue is too, I recommend a lot of people see a chiropractor sometimes, depending on what it is. They're also very helpful too. So a lot of times the mixture of medicines, chiropractic care, and physical therapy works wonders for people. And then if that's not working, then we look at getting an MRI, and then we try to figure out what truly is going on from a pathology standpoint. And then there's some things we can try, like some injections and things like that, before going on to surgery.
If you get to the point where surgery is really maybe your best or maybe even your only option, it's still, you gave me a list of things, and the first one was outpatient spine surgery, and my thought was, okay, is that a real thing? So it's hard to imagine having some surgery on your spine, such a sensitive part of your body and so important. It's hard to imagine doing that outpatient. So, I mean, is it done in a hospital setting or more like an ambulatory surgery center? Or?
Yeah, so it's actually done both.
Okay.
So we do a lot of the surgery now that we do is predominantly either outpatient, so home same day, or some people stay usually one night overnight in the hospital.
Okay.
And then they're able to go home the next day.
Wow.
So our techniques, the nursing care, the anesthesia care with pain blocks and things like that are, emerged so much over the last several years to where we can really get people up and moving a lot quicker. And so much of that, the kind of the roadblock, so to say, initially right after surgery is just kind of, a lot of it's that fear of
I was going to say, it's
the
probably
unknown.
Mental. Yeah, the mental thing. Yeah.
You have pain, you've never had this before, you had your neck pain or your back pain, but this is a different type of pain, and you're not sure what that means, or what, you don't want to hurt something, you don't want to do damage whatever we've done. And so if we can make you comfortable enough to kind of understand, here's the normal biomechanics, what you can and can't do, then now it's all about rehabbing. We've done this intricate surgery, The implant systems that we place in there are very stable, and so now it truly is just getting you back to life.
Is age play a factor with that? I wondered if, I mean, my daughter had back surgery, about a year and a half ago, and she did great. I mean, the pain was bad, but they kind of give you a whole team now. Most places. I mean, you have places you can call at 3 a.m. and a live person will talk to you. So that has changed the whole medical cultures like that. Yeah. But I mean, her being younger, I felt like she handled it really well. But then I thought, gosh, I don't know if I would be, somebody my age, I'm in my 50s, does age play a factor? And I wondered if there are certain kinds of conditions that would prevent you from being able to do the outpatient.
Yeah, so age does play some sort of a factor. I think some of it has to do with the extensiveness of the surgery itself, okay? So for instance, a lot of the neck surgeries we do, we actually go in through the front.
That's what I've heard.
Okay,
yeah.
And I actually had neck surgery myself a couple years ago. So we actually, the majority, I'd say 90% of the neck surgeries we do for the cervical spine, we go in through the front, we just kind of move things over. So there's not really any muscle dissection or anything like that.
Okay.
And so you don't have that as much of that pain. You do have some pain in kind of your back of the neck and your trapezius muscles just from stretching things back out to normal alignment.
Okay.
But again, that's kind of managed with icing it and some muscle relaxers and things like that, and you can get back to most of it pretty quickly. So even, I even do up to 3-level fusions in the neck, and people can still go home the same day.
Yeah.
A lot of things now, our understanding of cervical spine surgery especially has really changed over the last several years. We do a lot more disc replacements, at least in my practice, than fusions.
Okay.
And so the whole idea is to maintain that normal motion of the neck and the mobility. And the fear of people coming in and saying, oh, I don't have a fusion because that next level may break down or may have an issue at it. So before with a lot of our studies, they were always on like predominantly younger patients, didn't have a lot of wear and tear. But as now some of our other studies have come out, we're understanding that even patients with pretty degenerative necks, we can still do motion preserving surgery, disc replacements on them, and they still do really well long term. And so we don't have to do fusions on these people. And so we can do a 1 or 2 level disc replacement and get the patients home the same day within a couple hours of surgery.
I was going to say, is it require, even the outpatient surgeries, is it a situation where you would need to have somebody at home to help you? I mean, I'm just thinking if it was an older person, maybe that lived by themselves, they'd have to have somebody.
Yeah, so especially if you have a general anesthetic, you need to have somebody with you for the first 24 hours.
Okay.
Yes, somebody who's older, you may need help, making some meals at first. I will say there's also a night-day difference between neck surgery, cervical spine surgery, a lot easier to recover from than a lumbar surgery.
Oh, sure.
Okay, so that's one of the things too is having somebody help you around, getting to the bathroom, up and off the toilet, things that we take so for granted in our daily life, that suddenly becomes, a challenge. And that goes into even, like I said, so much of what we do is a multi-team approach, so even with what we do is, say if somebody has a lumbar surgery, when we sign up for surgery, we send them back to physical therapy, but the therapy then is designed with a different approach. So it's not just, oh, here's your exercises that you need to do. Now, for those couple weeks before surgery, they're teaching you how to get on and off the toilet, how to get in and out of bed, all these things that we want you practicing beforehand, so that you are accustomed to it and you're kind of well aware of, all right, this is what I need to do, so I don't end up having a bunch of extra back pain and all that stuff. So that's one of the some of these things that really makes recovery a lot better.
And I was going to say, like, years ago, my mother-in-law, I mean, she's passed away now, unfortunately, but this is like 20 years ago, she had back surgery, and my father-in-law went with her. I mean, I remember them going to classes ahead of time because he had to learn how to help her as well. So it can be, you definitely, if you can recruit, help, if it's a spouse, if you still have your spouse around, or maybe a child or a neighbor, it's definitely, you need that team help when you get home too.
It is. It's, yes, either your spouse, and if they can go to the classes, because we have a spine class, our joint surgeons have a joint replacement class. These are all things that to have that person who's your person after surgery to be there with you to really help make sure that you have the best possible recovery. Because if they're there learning, they know how to kind of help you, and all that. And if you do stay overnight, it's great to have them stay in the hospital with you so they can meet physical therapists, understand what the physical therapists are showing you.
Yes.
So that this all leads to a better recovery afterwards.
It does. I think it made a big difference for them. It did for our family when we went through everything with our daughter too. So we did get a call, Doctor, that somebody wanted me to ask for them. So Roger called from Fort Wayne and he wants to know what to do for pain from a broken tailbone. And I've always heard you can't do anything, but I don't know if that's true.
Yeah. So when I think of like what are the most challenging things that I take care of in my practice, coccyx pain, which is the tailbone.
Yeah.
So that is one of the most challenging because we don't have great answers.
Yeah. Would there ever even be would you ever need to do surgery?
Very, very
on
rarely.
that? No?
There's
Okay.
sometimes we can take it out.
Oh, wow. Okay.
We call it coccygectomy. So you go in and you actually excise that portion of the tailbone, the very bottom portion,
Okay.
and take it out. But even doing that, it's not a very hygienic area to go in for surgery because it's right by where you're taking care of yourself after going to the bathroom and all that. So there's a lot of risk to get infected and things like that. So if you have a broken tailbone, it's a lot of anti-inflammatories, maybe some muscle relaxers, using a inflatable donut to sit on to kind of help pad that area and trying to give it time.
Yeah.
And then if we can get you doing some physical therapy, there's some exercises that the physical therapist can show you. And sometimes we even just have our interventionalists, they do some injections and things like that to kind of calm that inflammation down.
Yeah.
So
I think around here with the ice, that's what most people have told me. They're like, I think I broke my tailbone because they slip on the ice, which and then most of them say, oh, I read online that you can't do anything, so they just kind of weigh it out. But at least, like you said, the anti-inflammatories to stay comfortable and so forth. So you kind of went over the motion preservation spine surgery, but can you kind of explain a little more about what that is? Is that, because you talked about disc replacement versus fusion. So
so in my mind, we have kind of two forms of motion preservation surgery.
Okay.
So one of them is disc replacements. So like I said, we're doing a lot more in the cervical spine, and now we're getting much better. The technology is better. The approaches are better for lumbar disc replacement. There's still some things that we're still very picky on those because we have to have the right indications in the right patients. Their anatomy, because we have to go in through the front, basically through the belly. So their blood vessel anatomy has to be right because the big blood vessels that feed your legs are right there. And so we have to make sure they're in the right places so it's safe to do the surgery.
Okay.
So those are kind of like, from an implant standpoint, motion preservation surgery. And then the other part is we're getting much better at just doing decompressions. So going in and kind of cleaning out the arthritis without having to do a fusion or replace any implants. And so we can do that with different techniques. There are certain ones where we can actually preserve what we call the midline structure, so the ligaments and everything in the middle. So we go in, we can clean that out without having to do a fusion. And so then that means that those other structures are still there for stability. Okay. And then there's also, I've been doing a lot more what we call endoscopic surgery. So kind of you think of like a sports medicine surgeon would do a knee scope or a shoulder scope. So I can go in, surgeons go in through a 2-centimeter incision.
It's so little.
We just use 2 of them, and we can literally go in, clean some of the muscle off the bone, and we can go in and clean out the arthritis. And we have special tools where we can go in, we can move the nerve sac over, we can take out a disc herniation and kind of just pluck it out very elegantly, get the pressure off the nerve, and then it's usually just a couple stitches and close it up.
That's it. Would that be, I would assume that's outpatient.
Yes,
then.
so that's outpatient.
That's amazing. It's hard to imagine when you talk about an incision that little. I mean, obviously, the patient's glad to hear it's not going to be like a, a 6-inch incision. But is that done robotically then? Is that?
So that's a great question. So when we do those types of surgeries, that's not robotic because we're actively kind of doing everything there.
Okay.
There are times where we do use a robot.
Okay.
In spine surgery, it's a little different than general surgery. You probably heard of using the robot for like the Da Vinci robot for
I've heard of that.
cholecystectomies or appendectomies, things like that. So that's used because we're not, you're not around the spinal cord, and so like you're literally within like millimeters of injuring things. And so we're going to try and get there at some point.
Yeah.
The robotics that we use today is more for placing the implants. So if we're going to place screws throughout the spine, we can do a scan of the spine, and then know exactly where in space then our instruments are. And so through small incisions, we can go in, we can put the screws, we can retract things, and then we can literally in space, I can literally take an instrument and I can follow it all over the screen because it can see it in space. So then through a small incision, I can go ahead, this far down into the body and scrape out the cartilage and take out things that we need to get out of there, and then we can put our cages or our implants in there through much smaller incisions. So it still allows us to do surgery with less destruction, less disruption of the muscle and all that, in a much very, very precise way.
Yeah.
Which becomes a very safe surgery for the
I was
patient.
going to say, that's amazing. Just even in my lifetime, I remember people, when I was younger, older relatives having hip and spine surgery and things like that. And it was a huge deal. I mean, they were in the hospital for over a week a lot of times, It just doesn't happen anymore.
Oh yeah, yeah. Even, I've been in practice now for 13 years, and it was routine for a one-level fusion to stay 3 days, and now 90% of them are home within the next day.
Yeah.
So, the things that we're able to do now it's amazing.
Well, and just from hospital stays we've had for ourselves and for our children, the worst place to try and get rest is the hospital. You would think that it would be it's not. They have to come check on you constantly, and it's, I think most people would agree if they've experienced it in the hospital, they'd rather recover at home.
Yeah, there's a lot of monitoring that the nurses have to do, and checks and all these things.
I mean, God bless them, that's great.
Yes.
You appreciate that. They're on top of it, but it's, you try and sleep for like 20 minutes here and there. So we do have another gentleman who called and wanted me to ask the question for him. So this is Lewis from Fort Wayne. So thanks for calling, Lewis. He's asking if spine compresses, if the spine compresses during the day are shorter than during the evening time. So I'm not sure.
Yeah. So actually, I believe that what they're alluding to is actually it's kind of sometimes that's often a grade school science fair project.
Oh, okay.
Kids will do if you measure yourself in the morning, you are actually taller than at the end of the day.
That's interesting. Okay.
Yeah, and so the whole reason behind that is because when we lay down, so our discs are just full of water. Okay. So they're full of a protein and a protein structure that absorbs water. So we lay down, our body kind of decompresses itself, and so you don't have gravity, and so it fills the discs with water.
Yeah.
And then as soon as you get up in the morning the next day, now gravity's kind of pushing on each of those discs, and so you have 7 cervical vertebrae, 12 thoracic vertebrae, and 5 lumbar vertebrae. So now gravity's pushing on all those discs in between, and so slowly and slowly the water, the hydration kind of goes out, and so you are a little bit shorter at the end of the day. And that's why. That's
interesting. I got to tell you, I'm done with science fair. I know your youngest graduated from high school. My youngest is starting high school, and we're done with the science fair. But that is, maybe for my grandkids, I'll pass that along someday. They can do that. So, all right, we have another question coming in. Got a lot of, I think, shy folks tonight, so they're having me ask for them. Doris from Fort Wayne says she knows 3 people who had the front, like you mentioned, the front-facing neck surgery, and they had daily migraines for the rest of their lives as a result, according to her. So she's wondering if there was a connection.
One of the things actually a lot of the studies have actually shown that when people have neck surgery, their neck or their headaches actually go away or improve. So a lot of headaches end up being what we call cervicogenic. So they were related to a lot of the arthritis. I don't know why it would be related to after surgery. Unless they've developed significant arthritis at some of the other levels. And so it could still be that if they've had multiple other levels fused and they have some really severe arthritis in the other levels that are still mobile, that could be causing neck pain. A lot of people have what we call occipital neuralgia. So it's kind of stems from one of the top nerves in the neck, and it actually kind of radiates up the back of their head and around the front. It can be very, very debilitating. And so sometimes their pain is actually occipital neuralgia that's causing the headaches and things like that.
Can they get any relief from I mean, I know some
Yeah.
people used to get migraines that they would have to give, there was a medication, they would have to give themselves an injection. They would get so bad. I don't know if it,
Yeah,
if that
so
falls in
sometimes
that
it's
line.
still some therapy,
Okay.
and then depending on what their X-rays and their imaging look like, it would be probably a shot with one of the interventionalists,
Okay.
and sometimes it's at those joints in the back, and sometimes it's at that nerve, and that's where we rely heavily on the interventionalists for some of those very specific injections.
All right. Well, I just want to remind people, they just showed me the 5-minute card. So we've got a few minutes left. That would still be plenty of time to get some questions answered. Again, if you want to text, that's a really easy way. This is probably the first show where nobody has texted. So I appreciate everyone who's called in. But if you want to text, that's so easy, 969-2730. If you want to just give us a quick question that way. And again, we keep your phone number private. Or the other way, of course, 969-2720. Call in, ask a question live during the show, or have me ask it for you. So we're going to go ahead. I just wanted to ask you about one other type of surgery that you mentioned was the muscle preserving surgery.
Yeah.
Because I think people don't realize how much you have to, cut through muscle to get to where you need to work. It's not really the most pleasant thing you want to think about, but I mean, it can be a lot for a patient to handle.
Yeah, so depending on the patient's whatever pathology they have, there are certain approaches that we can do instead of stripping all the muscle off the spine to get in there to get the access to what we need to do. We can go and kind of split the muscle, which ends up with a lot less scarring, and so the muscle still functions better after surgery. A lot of this has to do with like some minimally invasive techniques where we can go in, like I said, we can split the muscle. There's times where we can actually go in through people's side and avoid tearing apart all that muscle pretty much all together. So we can go in through the side, split your hip flexor muscle and go into the disc space and place implants that go in and act like a carjack or a shim. It literally goes in and pushes the bones apart. And when that happens, when a nerve is being pinched, once you push the bones apart, it relieves that pinched nerve. And so it gets the pressure off the nerve. And then, like for instance, like I use a lot of robotics, so we can go in then through a couple small incisions and place the screws, much less disruption to the muscle, so a lot less pain afterwards, quicker mobility and all that.
Wow. All right. That sounds like a much better deal than probably what it used to be. So, thank you so much, Mike. You texted. Mike from Roanoke. He's the man tonight. He asks, says a 73-year-old, asking about a 73-year-old has sciatica. He's used a steroid, a common steroid that hasn't helped. What else could help to ease the pain? We just can't say the brand name, unfortunately, but it's a very commonly prescribed steroid.
So sometimes it could be, depending on the medical issues you have, just regular anti-inflammatories. There's what we call neuromodulatory medicines. So there's some nerve pain type medicines that we can use a lot in patients. And then physical therapy, and if needed, the injections. And then obviously, if that's not taking care of it, then surgery. So.
And the steroid use is only temporary, is that correct?
Correct.
I mean, you can't, I just know that I've heard doctors say you can only maybe 3 or 4 weeks.
Yeah, we typically do what we call dose packs. There's a smaller one that's like, around 3 or 5 days. And the larger one that's about 7 days, 7 to 10 days. But that's pretty much it, because after that, it starts to potentially affect your adrenal glands. It can affect your hips, the bones, and things like that.
Okay, so that's kind of a temporary fix. So, all right, good to know. Well, we are just about out of time, so I appreciate everybody calling in and asking questions. I don't know if you have any advice for people over the summer months with that. You might be doing activities we're not used to, and sometimes you feel it the next day, so I don't know if you have, I know even my kids were out doing a lot of exercises and things they hadn't done for a while, and that now they were asking me for pain reliever. So
yeah, I mean the biggest thing is it's the old adage: lift with your legs, not with your back. Use good ergonomics is huge, so that you're truly staying within your limits. Use your legs, and I tell people a lot of times, like if you're doing something that's going to aggravate it, take an anti-inflammatory. If medically it's okay, ahead of time, to kind of get ahead of that, prevent some of that inflammation stuff for you instead of waiting and then now you're behind the 8 ball.
And don't make the mistake my husband made thinking he could just jump on a trampoline like he was 10 years old again. It doesn't end well the next day. So that's my advice. So thank you so much, Dr. Micah Smith.
My pleasure.
Orthopedic surgeon. So glad to have him back. Hopefully you'll come back soon. In the meantime, I want to remind you we do have another program next week. I don't know the topic yet, but I will be here and we'll have a live guest. And I'm sure it'll be a great show and you'll learn a lot. So please tune in next Tuesday night as well. Take care. Have a good evening, and we'll see you next week. Bye-bye.
The preceding program on PBS Fort Wayne is made possible in part by...
You gotta find your people.
Good morning.
The ones that make you feel whole.
Good. How you feeling?
You look so pretty today.
Bring it together, you got nothing to lose.
Good job.
In a world full of strangers, you don't know who to trust. You can't go it alone. Everybody needs help.
Go.
You gotta find your people, then you'll find yourself.